So, ladies and gentlemen, thank you very much for making the journey here today. I know it's been somewhat rather complicated by various industrial action with the trains. I'm not going to speak very long. My name is James Bland. I work for a company called Insightec, and together with the NTF, we are very, very happy to welcome you today, and we hope you get something out of this and that it's worth your journey. I'm going to be quiet. I'm going to hand over to a very eminent man, a chap called Professor Leslie Finley, and he will introduce the day and tell you a bit more about it. Thank you.
Well, can I repeat what James has said? Welcome on behalf of Insightec, the trustees of the National Tremor Foundation, the staff of the National Tremor Foundation, and those who have helped put this meeting together. This is our first face-to-face meeting since before lockdown, and it seems forever that we haven't been able to meet up. And our life has been dominated by Zoom conferences and Zoom committee meetings. The purpose of the meeting is to learn more about essential tremor, which many of you have. It's also to look at new approaches to the management of essential tremor, particularly focused ultrasound, and we have two experts to present on this. And it's allow you to network with others and share experiences, and hopefully then at the end you'll take away good memories of your charity, the National Tremor Foundation, and the treatments that are now becoming available. I would also like to repeat what James said, that travel has been difficult, and we're all delighted that there's been such a good turnout today, and I'm sure it's going to be a successful meeting once I get off the stage. I'm going to give you, can you not hear me? Just, if you can't hear me at any time, wave your hands, because I'm just assuming it's all going out. I think you can't do much in life unless you know something of history. It's the basis of everything. And I thought I'd give you a 5-minute history of the National Tremor Foundation. And it's my history. As you will be told today, essential tremor is the commonest abnormal movement disorder known to man. And it affects at least 1% of the population, and some studies will even put it as high as 5%. So there's at least 1 million of people in this country with essential tremor. Up until the 1980s, there's very little in the scientific literature on essential tremor. There were some good descriptions and some good case studies. But in the 1980s, 2 groups were working in essential tremor, 2 main groups, one based in London, headed by me as a young junior neurologist, because no one else at the Institute was interested in essential tremor, and one headed by Dr. Bill Collar at the University of Kansas. And these 2 groups were in competition, because we would publish a paper, and lo and behold, the next month, Bill Collar's group would publish a similar paper, or he would publish a paper, and then the next month we would. And this competition went on through the 80s. And sheerly by chance, in a bar in Boston, at the American Academy of Neurology meeting, I bumped into this chap and we started to talk. And I suddenly realized this was Bill Collar. And he said, "You must be Finley." So then developed joint research across the Atlantic, which in the 1980s the two junior neurologists, was very rare. And what we realized then is what we know now, and that is there was a lack of awareness of the importance and the prevalence of essential tremor. And out of that came the idea that we should form a charity to look after the interests of those with essential tremor. And we started this in the USA as the International Essential Tremor Foundation, and I was to run the branch for the UK. Within a year, 6 months probably, but certainly within a year, we realised that wasn't a good idea because people in the UK are not interested in international charities. They want to support their own charity. So at that point, I founded the National Tremor Foundation, which is the group today, which is now 30 years old. And I noticed one or two people who have come in this morning were attending our original meetings. And there was a very active group in Liverpool early on in the evolution of the Tremor Foundation. There's two other developments. Oh, I'm going to show you a photograph here. I want to show you this chap because we owe him a lot. That's Bill Collar. Generous, the best sort of American, kind. Although he was a scientist, he was very much a clinician, very much touchy-feely with patients, and the sort of guy you would like looking after you, or I would look like looking after me if I was unwell. There have been two fundamental changes. There have been many changes, but two fundamental ones. In the 1990s, when we were sort of in the post-birth stages, we wanted people to be members of the National Tremor Foundation. But in line with the charity, development of medical charities, we realized that membership wasn't what it was about. So we dropped the idea of memberships and annual fees and all the rest, and we just said, we represent all those with tremor, neurological tremor, specifically essential tremor in the United Kingdom. So whether you're a member or not, whether you go onto our website or not, we represent you in terms of dialogue with industry, with government, and elsewhere. The second change has been the development of the internet. And we've realized more and more as the years have gone by that our website has become increasingly important as our method of communication. And this was exemplified during lockdown, when we couldn't have our annual meetings, face-to-face meetings, our conferences, and so on. So the web has become very important to us. And hopefully it will become important to you, and you can influence your website through, if you go on the website, you will know how you can influence the web. So the four main reasons for the National Tremor Foundation, and they haven't changed. The first is to raise awareness amongst people, lay public, amongst doctors, and amongst politicians, government and administrators, to raise awareness, because people do not know about essential tremor. Shakiness is interpreted in all sorts of ways. And to put my hand up, I have developed a tremor. So I'm going to join, if I could, I would join the National Tremor Foundation. So I'm just letting you into a secret. So we want to raise awareness. When I used to attend the American Academy of Neurology meeting, which is the largest meeting in the world, on its annual meeting, in the movement disorder section, essential tremor was always the last lecture of the meeting. When everyone was rushing off to the airport to go home, they would give you the essential tremor lecture, and I used to do it quite often. And the hall would be emptying, and all the doctors would go, and I would be talking out into space because it wasn't considered important enough. So we need to raise awareness. Number two is to provide information, and then again, we do that through expert advisors and question and answer service from the foundation and our web. Because without information, we can't go very far. So we're here to support, which is the third reason for us, and that is to provide support for those with essential tremor, their families. And to that, we have developed support groups and again the web. And finally, and importantly, is to fund research. And fundraising is a very important part of what we do, because research on essential tremor in general has been very poor in terms of its funding. It's never been given importance. This wonderful new technology, which we're going to hear about, is going to be a catalyst, I'm sure, to more investment in research. We do this, we do all what we try to do through 6 unpaid trustees who are the committee. We have 2 staff, paid staff, one who works as a fundraiser stroke administrator, Jeff Salmon, and a digital consultant, Duncan, who's here. Where is he? He's somewhere out here. He's around the back there, Duncan. And he's responsible for the groundwork that he's been doing on the web. And of course, we have our volunteers, without which we wouldn't go very far. And Jackie Farrell, this morning, apart from the efforts of Insightec, Jackie Farrell has been most responsible for making this come to fruition. And unfortunately, she was tested positive for COVID the day before the conference was to start. And she's locked away in the hotel across there, and I'm afraid you can't go and see her. So that's the National Tremor Foundation. And we urge you to advertise it and talk about it and show your tremors to everyone. Because unless we raise awareness, we're still going to be back in 1992 when this organization was founded. Now, I've just got to do one. Now we should move on to the meat of the meeting, so to speak. You've all got a program. Hope you heard that. You've all got a program, and it's laid out there. And before lunch, we now have our 2 main speakers. The first one is Dr. Jay Paniker. Both of them are from Liverpool University and Liverpool Hospitals. The first one is Dr. Jay Paniker, Clinical Director for Neurology at the Walton Centre. He trained in Edinburgh, in Liverpool, but before that, he did undergraduate and postgraduate training in India. He's been a consultant neurologist since 2013. He has a specialist interest in deep brain stimulation, focus ultrasound, and normal pressure hydrocephalus. He's currently the lead for risk and clinical governance in neurology in the Wharton Centre, and neurology lead for the newly established NHS service for unilateral thalamotomy using focus ultrasound for essential tremor. And I welcome Jay, and I'll leave you to take over.
Morning, everyone. First of all, I would like to express my gratitude to National Tremor Foundation and Insightech for letting us come and speak to you all about this very exciting technology. And I also want to mention that it was very fascinating to listen to your experience of establishing the National Tremor Foundation. We are very grateful because the clinicians now stand on the shoulders of pioneers like you who did all the hard work, who came before us. Thank you. So how the talks are set up. So I am a consultant neurologist with special interest in tremor, Parkinson's, and other. Oh, can you not hear me? Yeah, okay. Is that any better? Yeah. So I am a consultant neurologist with interest in Parkinson's disease, essential tremor, and movement disorders. So traditionally, when we talk about movement disorders, people always think about conditions like Parkinson's disease. Essential tremor was a sort of a Cinderella condition in the sense that there was not a lot of research funding going into it, and even as clinicians, I have to say that this was not on the topmost list of our priorities. Even though many patients will tell differently, like patients can be quite disabled by this condition when it is quite severe. So how we have organized today's session is that I'm just going to give you a brief overview about essential tremor, how we diagnose and treat the condition, and also just a few quick slides about the surgical treatments as well, and then that will lead on to my colleague Mr. Farah, who is going to talk about the focused ultrasound treatment, which I'm sure most of you want to hear about. Sure, yeah. Sure, yeah. I do not have any disclosures. I have some patient videos, but these are with the consent of the patient, so I'll be grateful if nobody records them. So I already talked about the objectives. So what do you call a tremor? This may sound, it may feel like, this is very basic. How it is defined is, it is defined as an involuntary, rhythmic, and repetitive oscillatory movement of a body part. It is not a diagnosis in itself, so there are something like 20 different conditions which can cause tremors. It can affect different parts of the body, so commonly most people have tremors in the hands. That is the most obvious thing for most people, that's the most disabling, but it can actually affect any other part of the body, including the head, sometimes the lower limbs. And as neurologists, we define the tremors based on what we see. So is it present at rest, or is it present when you are holding things, or on action, on movements? And occasionally, there are other movements which can mimic tremors, which can look like tremors, and can cause confusion diagnostically. So it is important to remember that not all shakiness is due to a tremor. So I'm just going to show you a couple of videos. So I have two videos of people who were referred to us as essential tremor. So when you look at the video of this lady, you can't be blaming that it's essential tremor because it's a distal upper limb tremor, but there is a slight jerky character to it, and I'm just trying to trigger the, we call it myoclonus, stimulus sensitive myoclonus. So I'm just trying to trigger that by touching her hands. And in her case, the reason why she was getting the shaking was because she was on high doses of pain medications, which can actually trigger these movements. And once those the doses of those medications were cut down, the shakiness got better. So she didn't need any medications to treat the tremors. She didn't need an operation or anything to make it better. It was just that it was drug-induced, essentially. So in the legs, you can actually see the jerkiness as well. This young man was again referred as essential tremor, but you can see the very jerky nature of the shaking, especially when it is stimulated. So that jerkiness is something that we call myoclonus, which can mimic a tremor. And the importance of recognizing that is it is treated very differently to a tremor disorder. So this gentleman had a rare genetic condition called myoclonus dystonia, which responds very well to a treatment called deep brain stimulation. So the obvious conclusion here is that there are other conditions which can mimic tremors or which can be mislabeled essential tremors, and if we go down the route of treating these people as essential tremors, will be wrong. So I just wanted to stress, the reason why I showed those videos was to stress the importance of getting assessed by a neurologist, a specialist who can actually distinguish the different conditions which can mimic essential tremor before the diagnostic label is made. So the commonest question that we encounter in clinics when somebody is referred for a tremor, usually later on in life, is it Parkinsonism? That's the most important question that many people want answering. And the nature of a tremor due to Parkinson's disease is quite different to that of conditions like essential tremor. So Parkinson's disease classically causes what we call as a rest tremor. So this is a tremor which is present when you are not doing anything, when you are relaxed. For example, sitting and watching the television, the hand goes slightly shaky. Or when you are walking, sometimes people can have the slight shakiness of the hand. So you are not doing anything with the hands, and then the shakiness comes on. And it's often noticed by others, not by the patients themselves when it happens. And then as they start using the hand, the shakiness seems to go away. In very late stages of Parkinson's disease, it is different in that the shakiness can persist even when people are using the hand. But otherwise, the shakiness is classically what we call as a resting tremor. So as Prof. Finley said earlier, the essential tremor is the commonest tremor disorder and it's the commonest movement disorder. And it is the most likely diagnosis in somebody who is presenting with a bilateral upper limb tremor. So that is quite crucial. There are other conditions which can actually present with a unilateral tremor. So essential tremor is classically defined as a bilateral tremor. It usually affects both hands, fairly symmetrical. There can be a little bit of asymmetry, but it's usually fairly symmetrical. And it can occur at any age. It can start at any age, but usually we see this much more commonly. It comes to medical attention usually in people over the age of 40. So, the chance of somebody getting essential tremor usually seem to increase with age. So the older you are, much more likely it is that you will get essential tremor. And it's quite gradual in onset, often very mild to begin with. Again, it's not often noticed by people themselves. It's usually the family members or friends who notice that, oh, while you're holding the newspaper, your hands are a bit shaky. Or holding a cup, it is a bit shaky. Holding cutlery, the hands are shaky. So it's often picked up by others rather than the people who are affected by it themselves. So that's not uncommon. And it's often present for several years or even decades sometimes before people seek any medical help. In addition to hands, it can spread to other parts of the body like head, sometimes voice, and in rare cases even into the lower limbs. And often you get a positive family history. So it is a familial condition. There are strong genetic reasons why people can get essential tremor. So it's not uncommon for another family member to have the tremor. And many people, majority of people I would say, would notice some improvement with alcohol. So they're not talking about large amounts of alcohol. A tiny amount of alcohol can often result in an improvement in the shaking. So this is again often reported. And especially in severe cases, the tremor can be present at rest. So I said earlier about a Parkinsonian tremor, which is usually present only at rest. But even in essential tremor, it can be present at rest. And sometimes, again, this is something that can cause confusion. So on the odd occasion, I have actually come across people who has been treated as Parkinson's disease for several years when they actually do not have it. What they have is an essential tremor. Mainly because of this, they have a severe rest tremor. So that is something that can happen. So I just want to show these videos just to demonstrate what essential tremors look like. So these videos are of belong to a patient of ours who kindly let us use this for educational purposes. I'm sorry, it's sideways. So you can see when he's trying to hold the cup and pour it into the other cup, he's having quite severe tremors. So he's holding a pose and he's getting the shaking. It's more obvious on the right side. It's present on both sides. So this is how classically essential tremors are defined. So it's usually a postural and an action tremor. And you'll see in a minute when he's asked to touch the finger of the examiner, the tremors become much more obvious. So what causes essential tremors? Again, this is one question that often people want answered. Unfortunately, it's still very poorly understood what exactly causes essential tremors. There have been a lot of research and studies which have looked at this. And what we do know is that there are abnormalities in cerebellum and also in what we call as the a tremor circuit in the brain. It is abnormal, and there has been some evidence that there are some neurodegenerative processes going on, but it's still very poorly understood. And genetics plays a major role because 50 to 70% of people with essential tremor usually have someone else in the family with it, and multiple genes have been identified to be implicated in causing essential tremor. So, so these are the things that we know, but there is still a lot of things which are unknown about what exactly causes the essential tremor. And a few other facts about essential tremor. So if you have a standard MRI scan or a CT scan, this will be normal in essential tremor. And the routine blood tests, again, they don't help in distinguishing essential tremor from other tremor disorders. But sometimes doctors may want to exclude other conditions, like sometimes overactive thyroid can cause a shakiness of the hand, which can be sometimes difficult to distinguish from essential tremor. So often doctors check thyroid function tests. And if it is very young age of onset, sometimes people would want to exclude metabolic conditions like a copper excess state in the body, so they may do that as well. So I have these pictures of this dopamine transporter scan. So there are very rare cases, as I said earlier, sometimes Parkinson's disease and essential tremor can be, sometimes, especially in the early stages, it can be difficult to distinguish the two. And in that situation, something called as a dopamine transporter scan can help. So this looks at the dopamine receptors in the brain. On the left side, you see the normal looking scan. This is how a scan will look like in an essential tremor case. So you can see a inverted comma-like appearance or a tadpole-like appearance of the dopaminergic cells in the brain, whereas in a Parkinson's disease or anyone with a Parkinsonian syndrome, what you would see is that the tail of the tadpole is lost, and this is quite abnormal. So this is a test that is done, but not very commonly. And then there are other conditions which can mimic an essential tremor. So there is something called as an enhanced physiological tremor. So even normally, we all have a slight tremor. We don't often recognize it, but this is very mechanical. So the limbs and the head, when they are unsupported, they have a very slight tremor. Even in, practically in everyone, it is there, but it's so fine and very minor that nobody, notices it. But if you are anxious, or if there are some provoking factors, this can become more prominent, and then it can become a problem. So I've come across sometimes medical and nursing students self-diagnosing essential tremor because they get this exacerbation of the tremors, especially in stressful situations, and then this can get misdiagnosed as essential tremor. And there are various factors which can induce this shakiness. And again, it is very similar to an essential tremor to look at. Roughly 10% of people who get referred to movement disorder clinics have drug-induced tremors. So this is not an uncommon problem. So there are a lot of medications which can cause tremors. So many GPs like prescribing a drug called Stemetil, prochlorperazine it's called. So Stemetil is used to treat vertigo or nausea. And often people develop a shakiness after using this for a while, because this blocks the chemical neurotransmitters in the brain which help with fine movements. And so this can get misdiagnosed as Parkinsonism or essential tremor. And there are a lot of other treatments which can also induce a tremor, like anti-asthma medications, lithium. There are a lot of drugs which can actually induce a tremor. I just wanted to just mention this essential tremor plus. So again, when people come to the clinic, they often ask this question: can it get worse? Is it really going to cause other problems to me? Am I going to get dementia? Things like that people tend to ask. So very recently, only a few years ago, in 2018, the International Movement Disorder Society came up with this classification to say that sometimes you can get this condition called essential tremor plus, where you get a few other conditions attached to the standard essential tremor presentation, where you get other minor things like a little bit of unsteadiness, not very dramatic, but if you actually ask somebody to do a tandem walking, they may not be able to do that. Those kind of physical signs can be there. Not a dementia, but a mild memory impairment. So these are neurological features which can actually coexist in people with essential tremor. And when that happens, it's called essential tremor plus. And if that happens, as neurologists, we have a low threshold to look for other conditions which can cause this presentation. So this is actually a case that I took from a journal. So this was a 65-year-old chap. He was referred for deep brain stimulation for essential tremors. And he had very poor response to the standard medications which are used to treat essential tremors. And you can see it, he's quite shaky. And he has what we neurologists like to call ataxia, which is incoordination and imbalance when walking. And he also was found to have some memory issues on more detailed evaluation. So naturally, it did not fit in with the typical profile of somebody with essential tremor. So he went on to have some further tests, including a scan which was normal, and then he had testing for a very rare condition which can affect people usually later on in life. It's called Fragile X tremor ataxia syndrome. So this is a very rare condition which can actually mimic essential tremors. And again, if you are going to a neurologist for evaluation of your essential tremors, these rare conditions will be looked for, and you will be evaluated for that if you are having a tremor similar to an essential tremor. So, but I want to stress one point, and Prof. Finley told me this yesterday. It's quite important to remember that these are very rare conditions. You don't need to worry about it. Usually the diagnosis of essential tremor is very straightforward, and but there are rare situations where we actually need to look for other conditions which can mimic essential tremors. Sorry, I didn't mention the final diagnosis in that chap. So this chap's test for this rare condition was negative. It did not show up, but incidentally, it actually showed that he had again a different genetic disorder called Klinefelter syndrome, where there is an additional X chromosome. So just to clarify, men have two sex chromosomes, X and Y, and this gentleman had an additional X chromosome, and rarely this is something that can cause a tremor disorder as well. So how do we treat essential tremors? So one important point is not everyone with essential tremor needs treatment. It's only when it is severe that you actually need treatment, or if it is actually causing a functional disability. The reason being, medications, which are the first line treatment, can often be quite side effect prone. And then if somebody cannot tolerate medications, then we actually consider treating with surgical treatments. And there are two different surgical treatments which are mainly available in Walton Center, which are deep brain stimulation and focused ultrasound thalamotomy. And I just want to give you a quick overview of the standard medications which are used to treat essential tremor. So the first line treatment is that usually most people will prescribe will be something called as beta blockers. Propranolol is probably the most commonly prescribed drug. But it cannot be taken by people who have asthma, if they have poor circulation in the lower limbs, or a low heart rate, because the drug has the side effect of lowering the heart rate, and then it can cause dizziness and lightheadedness. And often you need to start at a very low dose and build it up slowly. And similarly, primidone is a very old-fashioned epilepsy medication, but it can also be very effective for tremors. But again, the main limiting factor is if you prescribe it to 10 people, probably 3 or 4 out of 10 people can tolerate it, the others can't, because it can be very side effect prone. So it can cause sleepiness, loss of balance, double vision, things like that. And then there are other medications. These are used when we really cannot offer any surgical options for patients, because these drugs, again, they don't work very often, and they can be very side effect prone. So not particularly great. So my colleague, Mr. Farah, is going to talk to you a bit more about the surgical options of treatment. So always deep brain stimulation was the conventional surgical treatment of choice for treating essential tremors, and it has been around for the past 30 years or so. And it's usually very effective. Essentially what it entails is that, as this cartoon shows, you have a pacemaker which sits under the skin over your chest, and there are electrodes which are implanted through a hole in the skull into this deep brain area which we call thalamus. And how it works is it helps us reset the abnormal electrical activity in the brain. So our brain is an electrical organ. So it is thought that there are around 13 trillion connections inside an adult brain connecting the nerve cells, and this is how we are able to function on a day-to-day basis. And the brain cells communicate with each other with chemical messengers and also through tiny electrical pulses. And in people who suffer from tremors, we know that there is abnormal electrical activity in the tremor circuits of the brain, and we can try and reset that abnormal electrical activity by resetting the electricity by pacing at a steady rate. So we are resetting the rhythm in the brain, so to speak, and that can actually be quite effective in improving the tremors. And this has the advantage that it can treat tremors in both hands. So usually when the electrodes are implanted, it's implanted in both halves of the brain and can actually treat tremors on both sides. So who will benefit from deep brain stimulation? So most types of upper limb tremors, irrespective of the reason, irrespective of the cause, can actually benefit from deep brain stimulation. But we generally are slightly wary as people get older, because it can be quite side effect prone as people get older. So it's often decided on a case by case basis. So we usually discuss it after initial assessment, we discuss each case individually in a multidisciplinary team meeting, which is attended by the neurologists, neurosurgeons, lot of other professionals, and then the pros and cons are discussed, and then only the decision is taken. And usually in anyone who have underlying gait problems or dementia or severe psychiatric problems or major speech impediments, we generally try to avoid implanting the electrode simply because it can cause more complications. One thing to remember is that after the implantation, people need to attend hospital for several appointments for programming to optimize the stimulation parameters. So this is also a commitment that you people have to make, and they should be able to have MRI scan safely. And then came along the focused ultrasound treatment, which has somewhat revolutionized the treatment of essential tremors, and I'm sure that most of you are here to actually hear about this new treatment. So I think it was around 2016, I think, when the first large-scale multi-center trial started for this treatment for essential tremors. So Imperial College London was the UK center for the trial, and the results came out in around 2019, and it was very exciting. I still remember we heard it at a conference in Nice, and we all came out of the conference feeling very excited about this new treatment. And I remember talking to Mr. Farah soon afterwards, saying that we should try and get this because it's such a good treatment option for our patients. So essentially, it is incisionless brain surgery, and one most important thing is there is no age cutoff. So in the past, as neurologists, we used to feel helpless because you would have people who are otherwise very well, somebody who is 80 or 80 years plus, and they are very severely disabled by a tremor, and they don't have any other major medical conditions at all. Otherwise, if we can deal with the tremor, they have a good quality of life, and the medications fail, and unfortunately, they cannot be offered deep brain stimulation because of the significant risk of side effects, and in somebody who is at that age. And then we used to feel extremely helpless, and this is where this has really come as a revolutionary treatment. So there is no age cutoffs. The oldest person who had the treatment was 96 years of age, if I remember correctly, and you can get the immediate result. So you actually, with the deep brain stimulation, you need multiple programming sessions often to get the optimal result, whereas with this one, you actually get a result straight away. At the moment, it's only licensed to treat one limb, but we are expecting that will change in the future. Who is eligible for this treatment? Anybody with essential tremor with at least moderate disability in performing activities of daily living. At the moment, it's not licensed to treat any other type of tremor disorder. In the US, it has received approval for treating tremor-dominant Parkinson's disease, but in the UK, it is still just essential tremor. They should be able to tolerate an MRI scan. And so, for example, if you have a pacemaker, which is not MRI compatible, you cannot have the treatment. Similar to deep brain stimulation, if somebody has severe memory problems or dementia, severe gait problems, if they have difficulty or imbalance with normal walking, or speech impediments, then unfortunately they cannot be offered this treatment safely. There are significant risks. So sometimes we get patients who actually come and tell us that even if the walking gets worse, I don't mind, I would like to have the treatment. So again, what we do is we usually take it to the multidisciplinary team meeting, have a discussion about the pros and cons of this, make sure that the person is very clear about the risks involved in it, and then only we usually proceed. And patients who are on blood thinners have to temporarily stop the procedure. So I'm going to hand over to my colleague, Mr. Farah, who is actually going to talk a lot more about this treatment. I'm going to skip that slide because I know that Mr. Farah is going to talk about the potential side effects and complications as well. Just to quickly go to the conclusion, so it's a commonest movement disorder is essential tremor, and careful evaluation is needed to exclude the mimics, and there are medical and surgical treatments, and surgical treatments are very effective, and the focused ultrasound thalamotomy is the new kid on the block, like it's highly effective surgical treatment.
Thank you. Thank you, Jay. Can you hear me? Thank you, Jay, for that excellent summary. Jay has agreed to answer questions, but I think we'll take all the questions at the end of the second presentation. Can I remind the audience that you can ask any question you wish, but you can't ask about whether you should be treated or how you should be treated. We can only keep it in the impersonal. So please bear that in mind. The next speaker is Mr. Jibril Osman Farrar, who is the consultant neurosurgeon at the Walton Centre. He is the clinical lead for functional and stereotactic neurosurgical service. He's been a neurosurgeon, consultant neurosurgeon since 2008. He's had an extensive training. He has a number of academic attachments and editorial responsibilities, including the Acta Neurosurgica. Lead us on.
Thank you very much, Professor Finlay, and thank you very much to the Tremor Foundation to have me. Okay, I'm going to talk about what are the treatment for tremor, neurosurgical treatment for tremor, focusing mainly on MR-guided focus ultrasound. But before starting that, a brief introduction on what is essential tremor. First classical report on essential tremor in 1874 in Siena, which was tremore essenziale semplice, simple essential tremor. This tremor is postural, kinetic, has got a frequency variable between 4 and 10, amplitude increase with age and frequency decrease with age, and there is a significant physical and psychological disability which can be associated with essential tremor. When we are looking at the incidence, a few studies have pointed all out two main factors. Essential tremor is underdiagnosed and is undertreated. The incidence is variable between 0.5 to 5%, but what is striking for me is only in a study in Spain, 4.8% of the patients were actually taking medication, and 77% were not previously diagnosed. Now, when you are talking about surgical treatment or treatment for essential tremor, medical treatment is the main stem. Surgical treatment is considered only when and if the patient and the individual is considered medically resistant. And surgical treatment available are RF lesioning, deep brain stimulation, and MR-guided focus ultrasound. And I put them in chronological order. In other words, RF lesioning was a thalamotomy and was available in the 1970s and 80s and is not available any longer. Very few units will do that. The current treatment are mainly deep brain stimulator and MR-guided focus ultrasound. Now, what is MR-guided focus ultrasound? This diagram will show you, first of all, the actual machine, and I think you've got a demo in the reception. You have the magnet, and then actually you have the helmet where the head of the patient is inserted. So you have a frame that will link the head of the patient, which is steady, to the helmet itself. The helmet will have a fluid membrane because ultrasound will need to go through fluid, they can go through air, and this fluid membrane allow the emitter of the ultrasound to actually target a specific area of the brain in order to control the tremor. And here you see one of the patients lying and linked to the machine itself. The overall time of the procedure generally is between 1 hour and a half up to 3 hours at times. Now, how the targeting is done, in other words, how we choose where we are going to focus the beam. The cleverness of this machine is the fact that the ultrasound needs to go to the skull. And in order to go to the skull without burning the skin, what they devised was a multiple beam which will reach one single point. And here you can see all the multiple beam. They are nearly 900 or 1,000, and they are all focused on a single area of the brain, which is a few millimeters in diameter. And here you have the frame which hold the head of the patient and actually allow the patient to be linked to the helmet of the machine itself. The MRI scan doesn't do the lesion. What does the lesion is the actual ultrasound within the machine. The MRI scan will allow to look at the brain and to look at the temperature that we are reaching with the beam of the ultrasound. So the beam of ultrasound will hit the tissue, and then they will burn the tissue, and the MRI scan will allow to look at the temperature and make sure that you don't go above a certain limit. Because the aim is to generate practically a small hole within a specific area of the brain. Now, in the Walton Center, we have been awarded the National Service alongside St. Mary, and this has been in October 2021, and we've done our first patient in April 2022. The indication, according with guidance, is mainly essential tremor and is a unilateral treatment, and generally has been done for dominant hand in the patient, depending right or left. This is briefly our workflow. So in other words, how a patient will be evaluated by ourselves. It's a very busy slide, but practically the patient is referred from a general practitioner to a neurologist, and the neurologist will screen and will decide if this is essential tremor, if the patient is suitable for the treatment. After it has been seen by the neurologist, it will be seen by myself in conjunction with the neurologist. The treatment is discussed, and naturally alternative treatment are discussed as well. So DBS is discussed alongside MR-guided focused ultrasound, and then at that stage a decision is made to offer the patient the actual treatment. We will need to get a CT scan of the head to look at the thickness of the bone. In other words, are the beam of the ultrasound be able to pass the thickness of the skull? Is the patient eligible for the treatment or is not eligible for the treatment? Once this decision is made, we'll go down the route of outcome measure, and we tend to get video of the patient before the procedure, after the procedure, alongside all different outcome measures to look at what is the impact of the actual treatment itself. Now, this is what I actually physically do, and as a surgeon, so it's the workup of my work to deliver the procedure. And so I review the CT scan, the patient is eligible, and then I will acquire an MRI scan of the brain of the patient, and I will do what we technically call targeting. And the targeting is an anatomical targeting, atlas-based targeting, and DTI, which sounds very complex, but it's nothing else than looking at what are the anatomical structure on the MRI scan and decide where to put the focus of the beam of the ultrasound, because we will need to tell the machine where actually to focus the beam itself. So this is an MRI scan of the brain, and what you can see are different cuts, but what we will tend to do is to reconstruct the anatomy. So that is the VIM, that is the actual target where we are going to put the focus of the beam, and you can see the target itself here. And on this coronal cut, a coronal cut is a cut which goes in this direction, what you see is the anatomy of the structure which are at the level of the basal ganglia. When people are talking about thalamotomy, and this is an MR-guided focused thalamotomy, they are talking about a small lesion and burn, which is actually focused in that specific point. Then what I tend to do is to reconstruct the tract, the white matter tract. Why this is important? Because the white matter tract are what is controlling your motor function. So what I want to do is to create a lesion in the thalamus, but I don't want to actually lesion your pyramidal tract, because otherwise you will get an hemiplegia, so you can get a potential neurological deficit. And this is what is the tract. And with modern technology, we are able actually to reconstruct in 3D all the anatomical structure. And again, this is the VIM and where the lesion is done to control essential tremor. Postoperatively, we tend to administer the outcome measure in order to look at what has been the impact of the treatment. We do a video after the procedure, and then we acquire an MRI scan, and you will see later on why it's important, because at times you may have some degree of swelling, and this will enable us actually to look at what we have done and if there are any sort of complication linked to the procedure. And again, this is a targeting MRI scan. That is the dot where the lesion is done. The lesion is generally between 6 millimeter to 10 millimeter in diameter, and shouldn't be bigger than that. And that is the lesion. So that is the thalamotomy itself. So this is practically a preoperative scan, and you can see in this area there is nothing. And here, what you see is this circle, and this circle is what actually controlled the tremor. That is the big difference between DBS and MR-guided focus ultrasound. With MR-guided focus ultrasound, we perform a lesion which is a permanent lesion and is not reversible. The DBS will be inserted more or less in the same target, but potentially can be reversible. And again, here you're looking at some of the anatomical reconstruction with all the tracts. And again, all this anatomy which is useful. And I've got few video to show you of patient before the procedure and after the procedure. And then I hope they work. So this is before the procedure, and we treated the right hand in this patient. Okay, so that is the preoperative video. We tend to get more than one preoperative video for different kind of action. So each patient will have a file of 4 to 5 of this video. I hope this is the postoperative one, and is the right hand that has been treated. And this is within 24 hours from the treatment. And you can see that the nurse is asking him to hold it from the handle, but then there is a relearning of the movement, and he's more comfortable, despite the fact that he's got no tremor. Yeah, so that is one, and so I've got another few video. So this is the same patient that Dr. Paniker showed you beforehand, and this is the video that you've seen, and that is the preoperative video, and that is the postoperative video. So this guy is coming from downwards, and he was able actually to start again playing piano. He wanted to play piano for several years, and then he was able to do that. And you can see the hand, which has not been treated, is still... So this one is a very interesting tremor, very interesting essential tremor. The job of this individual was to restore old furniture. And he needed to use, he didn't have very much tremor when he was eating or drinking, but it was affecting his work in the restoration of furniture. And he wanted the tremor to be controlled. And that is him postoperatively. And you can see what he didn't want was the tremor when he was using a screwdriver or any other instrument in his line of work. One thing that I forgot to mention, during the treatment, we will have to shave the head completely, and all these patients post-operatively, you will see they've got a head shave. The shave of the head is necessary because the beam of the ultrasound will be blocked by the air. And you can see the other hand, which has not been treated, which is the left hand. And let me see if I can run this one. So this patient had a significant tremor, which was bilateral, and quite a frail patient, and the tremor is bilateral. Before MR-guided focus ultrasound, the only thing I could have offered him was a DBS, and my concern in this situation would have been the actual hardware, how he would have tolerated the actual procedure, the potential of infection, and was an ideal candidate, as Dr. Panica mentioned, with MR-guided focus ultrasound. And this is him post-operatively, and you can see there is still the tremor on the non-treated hand, but the treated hand is very still on at rest, and then you can see that it's still on the postural component, and then it will be, and is much improved on post-operatively. And you can see the intentional part of the tremor is controlled. And I'll show you, I think possibly this is one of the last one. And this one was a quite severe tremor, and you see it's distal, he's not able to hold the cap, he spilled the fluid all around, and this is him post-operatively. And I can jump. So this one, again, you can see this has been the first patient that we treated. And you can see that there is a shake in the hand, an intentional one, and then you see post-operatively a very good control of the tremor. This is done possibly within a month and a half. So these are the MRI scan of our first patient, and here what you can see is the lesion, which is the target, in relationship with the different structure, and that is very important. So corticospinal tract, so this is the motor function of the individual, which is protected, and the lesion which is medial to it, and the lesion is within the actual VIM, which is the pink structure. And again, you can look at it here, but again, this is for all purpose, a small hole of 6 millimeter to 10 millimeter in diameter, and is a part of the brain which has been permanently lesioned. And again, here you can see very clearly the lesion, and what you can see around it is some degree of edema, which is normal, and every single patient will have that, and this will generally tend to resolve within a month and a half. Now, is this procedure without complication? No, no procedure is without complication. One of the things that is very important to understand is that there is a possibility of edema, but the edema which will occur in every single patient may not be symptomatic in some of the patients, or may become symptomatic in some other of the patient. And the edema generally tends to resolve within a period of 30 days to 45 days, but it's something that the patient needs to be aware of, and particularly will tend to diminish this with the administration of corticosteroid. So this complication, which, as Jay mentioned, can reach up to 10%, they are generally transient, but they may not be transient in some cases. So when you're looking at our experience, we treated a total of 11 patients. We are doing now 2 cases a day. We achieved on a short follow-up 100% control of the tremor. So each one of the patients that we treated, we controlled the tremor in those patients. But one of the limitations is the fact that I don't have a long-term follow-up. And one of the issues could be a recurrence of the tremor later on down the line, 5 years, 10 years down the line, and that has been described. But I don't have experience personally on this. When you're looking at delayed complication, we had 1 case of edema, which was quite significant, and there was some degree of instability of gait, which is still resolving at 40 days. When you're looking at the improvement in quality of life, baseline 60, we achieved a 90 on average, and therefore our early experience is very satisfactory regarding the tremor control and the efficacy. The actual procedure is not a walk in the park. It's true that there is no skin incision, but this is a procedure in which the patient is on the MR table for 2 hours to 2 hours and a half, and therefore you need to have an individual which is ready to cooperate with that and able to tolerate it. Now, beside the MR-guided focus ultrasound, what are the other surgical alternatives? Deep brain stimulator. Deep brain stimulator has been around possibly since the year 2000. These are the 2 electrodes, and this is the procedure itself, which is done in our center under local anesthesia. Deep brain stimulator is different from MR-guided focus ultrasound. It's different because these are electrode implanted, will stimulate certain specific target, and will enable the patient to control their tremor. Technology is improving. You can do bilateral implantation. It's fully reversible. In other words, it's fully reversible inside the brain. The scar on the skin will be permanent in the patient, but actually is not a lesioning technique. That is the difference on a philosophical point of view. We are able now to have adaptive stimulation. In other words, the electrical stimulation can be linked with the movement of the patient. So you move your arm, the stimulator will kick in and give you the stimulation. You don't move your arm, you don't need the stimulator doesn't give electricity. There is a burdening in programming, so the programming needs to be done on a frequent manner, I would say, particularly at the beginning of the implantation. One of the advantage in this present time is the fact that I can treat every form of tremor, and I can treat bilateral tremor. So unilateral, simple, essential tremor, MR-guided focus ultrasound can address that, but the very moment in time in which I have severe bilateral tremor and is not essential tremor, but is a complex tremor with a dystonic component, then MR-guided focus ultrasound, I won't be able to achieve control of the tremor itself. And naturally, in our service, we offer both procedure, and we are able to deliver both procedure in this moment in time. And that's it. Thank you very much.
Well, both speakers have agreed to answer questions, so you can direct them through me. And James, do you want to do that microphone so that we've got wonderful presentations? I mean, to try and put over what they did in an hour was just mind-boggling. So, questions?
I just want to ask why you can only treat one tremor.
One side?
Yes.
I can answer that, but perhaps it'd be you should tell them.
So to repeat the question for the room is, why can we only treat on one side using focused ultrasound?
Speech problem. If you do a bilateral thalamotomy, you achieve control of the tremor, but with the experience in the 70s and 80s, when they treat both sides at the same time, they had speech problems, so dysarthria, and the patient was not able to speak properly. One way you can go around it is to stage it. So to do a lesioning on one side, then wait 6 months to 12 months, and then do the contralateral side. But the risk for speech is still present.
Yeah, another question?
What I want to know is, my husband has essential tremor, and he gets anxious. Would that anxiety go away after you've had treatment? Or do you still get that anxious feeling?
I don't think it will go away. In my experience, it doesn't tend to go away. It's a functional motor control of the symptoms, but not surely that kind of thing.
Say, I'm going to be a bit dominant. That's a very good question. The question you should have asked, if somebody has anxiety, will it go away, and not refer to yourself, because we're not supposed to give out medical advice at a conference. It's a difficult one, I know, but I got my fingers burnt before with this, so...
Sorry, we'll let you off, don't worry. No, don't do it again. 2 seconds. Try, I can come.
It's only a general question, but will we get any of the handouts or the information that was up there? The slide.
So I can answer that if you want, Prof. So the session is being recorded and will be available on the NTF website for you to watch back. So if you, rather than getting handouts, we've gone high tech. You can go to the NTF website, and you should be able to access the recording there. Although we will have removed the patient videos due to patient confidentiality, so that they won't be there. But at least the information will be there for you to review at a later stage. 2 seconds.
Hi. I was wanting to ask, because there was the mention of the physiological tremor as well, so I was wanting to ask about the key diagnostic differences between that and essential tremor, and also if there's typically any of the other sort of neurological symptoms associated with essential tremor as well.
The first question was the difference between enhanced physiological tremor and essential tremor. Do you want to do that?
So, first of all, the enhanced physiological tremor, the severity itself is the amplitude of the tremor is much less severe than the classical essential tremor. And it's usually the key differential feature, I would say, is the precipitating factors, the triggering factors, which seem to bring it on. So it is essential tremor. It is not something that fluctuates. So if somebody has essential tremor, if they are actually asked to hold the hand up, maintain a posture, or holding something, the tremor will always be there. Whereas with enhanced physiological tremor, often it is very responsive to triggers. And at other times, when the triggers are not there, the tremors are seem to kind of fade away. So that is one key differentiating feature. And the age of onset is also quite different. As I mentioned earlier, it's enhanced physiological tremor. We seem to kind of find much more commonly in relatively young people. Like they usually present with this mild tremor. Especially triggered by stressful situations and things like that. So that's how we actually distinguish.
What was the other part of your question?
The other part of my question was if you see any of the sort of other neurological symptoms associated with essential tremor. So, you know, stuff like brain fog or fatigue or other sort of stuff like that.
The answer is no.
So Prof has already answered it. So you don't, classically you don't see essential tremor with fatigue or brain fog or anything like that. In large research studies, you know, when people, one of the things about human body is that if you go at it with a microscope, if you kind of, you know, start looking for things, you will find things. That is the nature of, you know, human body in general. So if people have looked at the cognition, you know, our memory assessment in research and found that there are minor issues with it, but nothing that should really clinically manifest. So, you know, practically no one who comes with essential tremor to my clinic would have any major memory issues. You know, so that is the answer.
Yeah, I'm coming. This gentleman on the right down here.
I'm aware that there hasn't been any research on this subject, but if after 5 years essential tremors reoccur in the right hand, can there be a further operation to do the same procedure? But of course, your research hasn't shown that at this point?
The answer to that is yes. You can do a redo thalamotomy. The problem with it is that you may have not as good result as you had initially, and the actual surgical risk will be higher than on the first go, particularly when you're looking at instability of gait or motor symptoms. It depends on how big is the lesion. In other words, the lesion is what you're burning. If there is recurrence of the tremor, is that more tissue that you can potentially burn, yes or no? And that is the reason. But the answer is yes, you can do it.
Sorry, I just wanted to mention that we do have long-term follow-up data of 4 years, and which shows good tremor suppression 4 years down the line.
You wanted a question here?
What's the difference between essential tremor and dystonic tremor in terms of symptoms and treatment?
Okay, that's an excellent question actually, because you know, many neurologists get confused between the two, and there is sometimes a bit of overlap. So dystonic tremor, the process that is happening in the brain is different, and there is often a posturing, often of the neck or of the limbs. So when there is an element of dystonia. So dystonia essentially means there is overactivity of the muscles, essentially what we call as the agonist and antagonist muscles essentially fighting between each other. That's actually what causes the posturing and pulling. And very often we find that in dystonic tremors, they often start in the head and then go on to the hands. Whereas in essential tremors, usually it's the other way around. It's usually start in the hands, and then often in some people it can go to the head. And how we in the clinic, how we distinguish is, you know, looking for what we call as a dystonic posture. So often people have a little bit of a torticollis posturing of the head to the side, and often there can be a little bit of shoulder elevation. One shoulder can be pulled up. These are subtle things, but we can actually pick that up in the clinic. And coming to the upper limb tremors, usually there is quite significant asymmetry in dystonic tremors. So dystonia is something that usually affects one limb much more than the other, especially at the onset. So when we see somebody with a bilateral upper limb tremor in the clinic, we often ask at the onset, where was it? Like, was it there on both sides or just one side? And often the story is that at the very beginning it was just a single limb prominent tremor. And sometimes there can be task specificity as well. So I have a gentleman with a dystonic tremor who finds that the tremor only appears when he is actually using a pen, but otherwise he can do everything else without any issues. He's okay using cutlery, things like that. So those kind of task specificity can also help. So those are the key clinical differentiating features between the dystonia and essential tremor. Prof, would you like to add anything at all?
No, I think you covered it very well. The simple answer is that the tremor is associated with dystonia, abnormal contraction and posturing of muscles. That's the baseline question.
Are they mutually exclusive?
If you have dystonia and a tremor, we would call that dystonic tremor. So we wouldn't make a diagnosis of essential tremor in someone with a dystonia in a limb. It would be dystonic tremor. And the picture of the tremor is also different. It looks different. You can look at someone's tremor, it tends to be more irregular and rather than the rhythmical contractions you see in essential tremor.
What about treatment differently?
The answer to that is there is an overlap in treatment. You can use the treatments that have been suggested for dystonic tremor. For the tremor, you can use lesioning of one sort or another. So it's not they're not mutually exclusive.
So independently of what is NICE guidance, so the NICE guidance says the lesion can treat only essential tremor. But independently of that, personally, a dystonic tremor, I will consider a DBS. I will not consider a lesion. Because in order to treat a dystonic tremor, I will have to target in a slightly different manner of what I would do for the essential tremor. And therefore, the safety parameter, for me, becomes a bit blurred. And I will suggest individual with a dystonic tremor to consider a bilateral DBS with an implantation with a lead, because with a lead, I will be able to go deeper than I can go with an MR-guided focus ultrasound or a lesion technique. That is my personal opinion.
Okay, so we do have a half an hour of general Q&A, which will be the last session. So in the interest of us all getting a bite to eat and a drink, I think we'll take one more question, because this lady's been very patient. But we'll call this one the last one, and then we'll break for lunch. So thank you very much.
Is it common for people with essential tremor to develop a poor sense of balance?
What are you going to say?
So when somebody with essential tremor has poor balance, we always look for other reasons why they have the essential tremor, or why they have the loss of balance. We don't just pin it on the essential tremor. That's the short answer. We definitely look for other reasons.
The other thing is that essential tremor is common in the elderly, and balance impairment is common in the elderly. So the two go side by side. And scientists love to publish papers. That's what we do when we, and there's been a lot of papers about the balance disturbance in essential tremor. But it doesn't take much imagination, really, that if you've got a tremor that's big enough, it will affect how you walk and thereby your balance. So I think Jay gave the right answer.
So in which case, thank you very much for your patience this morning, for listening to the two wonderful talks. Thank you, Jay. Thank you, Jibril. Thank you, Prof, for introducing. Thank you. So yeah, we've got a couple of hours now. We'll reconvene at 2:30. So feel free to walk around the information tables, have conversations, and network, and get as much out of the day as you can. So I'll see you again at 2:30, or if you come and talk to me before. Thank you.
Could we encourage the people, could somebody get a message out there and ask them to come in? Because there are a lot of people who won't know. Welcome back, everybody. The first thing I'd like to say is that we think one or two people were a little upset this morning because they couldn't hear at the back. So anyone who can't hear during the afternoon session, stand up and wave your hands so that we know. I don't want anyone going away saying I couldn't hear it. If you can't hear, it's your fault because we're asking you to let us know. So everyone will hear the words of wisdom that are coming out. The other bit of news is that Jackie is out somewhere in the square and Kitty has been down with a food parcel. She's been taking some goodies, tea and best wishes from all of us. The fact that she put an enormous effort into this meeting and is unable to be here. So that's good. So we got a very exciting afternoon, and we're going to start off with the interview with Rob Mallard, and I'll introduce him in a second, though he needs no introduction. And this is going to be followed by an open session expert panel, which will be our two experts here, and you can address questions to any of the trustees, and they will answer, won't you? Yes, good. And then finally we have a closing remarks by James, who's also the power behind the throne. So moving on first to Rob Mallard, who sits there. I used to follow Coronation Street when I was a student, and I used to follow it all the time in the days of Len Fairclough. And I understand he's left the programme. No, I noticed that. But Rob, I hear his name often because he's contributed so much to our foundation and your foundation, and you know he's important to all of us, and he's going to expose himself to a question-answer session, and I look forward to the answers.
Thanks, Rolf. First of all, I will start by apologising because I think I'm the first person up here with a tremor. So you'll see this waving around a lot, but I'm sure you will forgive me with that one. So first of all, just to welcome you, Rob. Thank you so much for giving up your time and joining us here. How are you?
Mine's well loud. I'm good. I'm not bad at all. Yeah, it's been interesting to listen to what people have to say and to meet other people who've also got a tremor. Yeah.
Fantastic. Thank you. Thank you. I thought just to kick us off, if you could tell us about yourself as a child, your interest in drama, your interest in acting. When did it start? Was this primary school, middle school? How did it go?
My mum used to work in the nursery, and the one that I went to, and the first thing I'd do every day when I got there was put a tea towel on my head and used to run around as though I was in a Disney. I don't remember which one it was, but I thought I was a Disney character. Can't remember. So she seems to think that it started about then. So I'd always wanted to be an actor. I didn't realise I could get paid for it until much later on. I thought it was just that thing that my parents let me do because it kept me out of trouble. But then I realised that actually I could make a job out of this.
Yeah, so all the school productions and such things?
Yeah, school productions, choirs, then drama classes on a Saturday, college, and then to a drama school in Birmingham.
Right. So are you actually from Birmingham?
No, I'm from Oldham in North Manchester.
Right. Excellent. And then you mentioned drama college. What sort of things were you doing there?
Well, it's a bit weird. So if anyone, I always used to say, if anyone could see inside of what we were doing, they'd say you're all wasting your money, because it was ridiculous to watch. It was a lot of like rolling up and down your spine, a lot of relaxation methods, which now have come in very useful, because one of the best ways to get your tremor under control is relaxation, because any extra adrenaline that goes into your nervous system is just going to make it worse. So yeah, about a year and a half basically of rolling up and down your spine, relaxing your jaw, doing breathing exercises, and then once everyone had kind of mastered that complex trick, that's when they started letting us have a look at scripts and stuff like that. Yeah. because I have 3 years.
Right, thank you. I was going to ask you about your tremor, so moving on to that. At what age did you first notice your tremor? And was it you that noticed it? Was it your parents, friends? How did it come about?
I was 14, and I think it was friends that had noticed it first. It was in my left hand to begin with, and it was slight. It was barely noticeable. And for a few years, I thought it was an overactive thyroid. I don't know whether anybody else got that diagnosed. People nodding there, yeah. I don't know that it was a thing, because apparently one of the symptoms of overactive thyroid is tremor. And so I very nearly went on thyroid, whatever it is.
Propanol.
Say again.
Propanol.
That could be it, yeah, that could be it, yeah. And my sister, because there is some thyroid issues in my family, and my sister's had hers removed, so she has to take something to. Is this going off? No, it's all right. She has to take something to replace the chemicals that she doesn't get anymore. So we just assumed that was probably what it was, since there was other people in my family that had it. And then it was as it got worse as I got older that I went back to a doctor. And he said, "Oh, it's an essential tremor, there's nothing we can do, see you later." And I didn't realize at the time that it was progressive. He didn't say anything, didn't say that it was progressive, just thought that it was going to stay the same. And then it got worse again, and I went back to see a different doctor, and they explained what it was. And then I went home and looked it up, and then I realized that it was something that I was going to have to contend with much more seriously than I had been before, because I don't know, part of me seemed to think that it would go away. I don't know why, but because a lot of people seem to think that you've got some sort of anxiety issue related to the tremor. A lot of people who go, "You sure you're not just anxious and stressed?" Yes, I'm alive, but on top of that, I also have a tremor that goes along with it. So it was good to finally get a diagnosis. And then that led me to, I went on to this morning to talk about Coronation Street, and that was how I ended up going on to talk about the tremor, yeah.
Have you got any coping tips you'd like to share with everyone here?
Yeah, well, we're just doing a few of them over there, like all the breathing stuff that we did at drama school, that does help, because especially before a take on something, if I have to do something that, like everyone here who's got tremor knows, it's the tiniest things that become the hardest to do, things that most people don't think about. And that's often the way with filming the scenes as well. The hardest thing is not remembering the lines or finding the emotions for the scene. It's, can I hold this pen still for 10 seconds whilst they get this take? Or now, because they use a lot of mobile phones in the show, there's a lot of getting a shot of the screen because people need to see what's written on it. And it's like, absolute nightmare. Your hands just shaking all over. And then you become hyper-conscious of it. But I have found certain things that we were just doing before, which is taking my mind out of what I'm doing. So if I'm trying to hold the microphone and paying attention to it, it's a lot shakier than if I'm holding the microphone and I put my attention on something else, like a different part of the room. And I try and do that sometimes with things that I've got to hold in scenes. And at a bar, in my own life, I spend quite a lot of time in them. So if going to take a drink and you can already feel someone looking at you because they might have spotted you and gone, "That's that guy on Coronation Street." So you already got someone staring at you, and then you go to take a drink and you go, "Oh crap, this is going to go everywhere now, I can just tell." Taking your mind out of it, especially the more of them you've had, it's easier to do. So yeah, I find that helps.
Thank you. You mentioned going on this morning, and that was my first understanding that you had a tremor. Did you receive a wave of emails, contact from people supporting you in your tremor after that?
Yeah, I did. Jackie was got in touch. Tremor Foundation, and then more often than not, it was younger people who would just come up to me in public and just put the hand in my face and go, "Look," and just show me the hand shaking like that. So sort of like a secret handshake that you knew you were in.
So I think Rob's saying we're all in a secret club
here. We're all in the
here.
same club. But the thing is, was not knowing what to do with it. I mean, a couple of times, someone said to me earlier that it was through this morning, and they were like, "Oh, thanks for doing that." I was like, it's very weird because obviously everyone here until today was a stranger to me, so you don't know. It's weird to think that that's had some sort of influence on people's lives. But if it has had a positive one, then I'm happy to do it, and I'll keep going on and talking about it till I'm blue in the face.
You did join us at one of the online Zoom meetings, which Jackie organises online Zooms. So if anybody hasn't come across them yet, have a look on the Tremor website. But Rob's joined us on a few. And you mentioned there that you eat small amounts regularly, and that helps your tremor. Have you got other coping tips, other suggestions that would help us?
Yeah, so I find that if I've not eaten anything, then it's worse. I don't know whether other people have this. I think it is. It tends to be. So yeah, eating as often as possible, little and often as possible. I stretch my arms out quite a bit. Like you can put them, you put it in a flat wall to show you, but against the wall like that, and then turn yourself out and just hold it for as long as possible. And then when you come back, you will get, it is just sort of like a release of the build-up of tension. I found that can help. But otherwise, no, I was saying to a few people before, I did try the propanol, is that propanol, and it had no effect. Apart from it did make me sluggish and a bit withdrawn, actually. But I think that's because they're for anxiety disorders, really, aren't they? So yeah, I've ended up not taking any prescription medication for it, just stretches and making sure that I've eaten well. Sleep's a big one. You don't get enough sleep, and a tiny bit of alcohol, just a tiny bit. Regular, often intervals.
You mentioned a couple of the things you do when you are on set. So without giving storylines away and such things, what the ways of supporting yourself with props and such things? What do you do, if you can give us an insight into what life is like when you're filming?
So it'll usually be stated in the script that there's a physical. But what I try to do is I use props in every scene that I'm in because I want to get used to it. So you come at it head on and you say you're never going to get. A lot of it's the confidence as well, because you think I don't want to pick this up now, because I think if I pick this up I'm just going to shake everywhere, and so you just go, I won't touch it. But if I do know I have something that's in the script that has to be done, I'll just whilst they're setting the lights up or waiting for someone to get costume changed or whatever, I just practice it over and over again, do the breathing, stretch my arms out, and then go to the director usually and say, we're probably only going to get 1 or 2 good shots on this. I had to do something 2 days ago. We're filming Christmas, and I had to hold a bauble with a picture in it, and they had to get a close-up shot of this picture, and the bauble's got glass over it, so there's a glare on it anyway. So he was like, it's a very specific angle that you have to hold this at, otherwise the camera won't see it at all. We were there for 45 minutes, something like that. I said, do you want to get somebody else's hands in to do it, because it's just not going to go well. Eventually we did get it, but it was one of those ones where you can sort of feel, because it was a Friday afternoon as well, so you can sort of feel everyone going. But, what can you do?
So looking into the future with your acting career, are there any roles or characters you'd like to play?
Oh yeah, loads. I'd love to have a go at most of the Shakespeare roles. But I'm thinking stage might not be a good thing for me to do, because a live audience is terrifying, and like I said, any adrenaline is just going to make it worse. So I'd love to, but I'm a bit worried that I can't just, if I shake or drop something, I'm not going to be able to say, oh, sorry, can I do that again? Can I just go back? You don't mind, do you, if we just go back? So, I don't know. Or if I do something, it's got to be maybe a character with a tremor. Maybe if Julian Fellows fancies writing something else with a person with a tremor, I am available. So, I don't know. Yeah, but I would like to.
Great. I am so aware that we're running out of time, which is so unfortunate, but just to ask you about your work with the National Tremor Foundation, we are trying to get the message out that tremors do affect people of all ages, and Rob has done some work supporting the young adults. So are there any words that you could give to the young adults out there, out here, and also the people that are watching this on the live stream?
Yeah. Try not to worry about it so much. I know that's easier said than done, but try to take a healthy dose of humour with it. All of my friends get a good laugh out of me. I get a good laugh out of me, because I think if I didn't, I would just be very frustrated all the time. So since there's nothing really that can be done for it, unfortunately, it does sort of boil down to an attitude after a while. Obviously, people are at different stages, completely different stages of having the tremor. So it's mainly in my arms and my legs. Occasionally, you can hear it a little bit in my voice. But I've met other people who it's completely debilitating. So you couldn't just say to that person, "Oh, go on, just have a laugh," because obviously it's a lot harder. But I would say, laugh rather than cry about it. Take medical advice. Try anti-anxiety drugs if it's something that you want to give a go, and then obviously now with this brand new treatment, which is a game changer, isn't it? So, yeah.
Right, thank you so much.
Thank you.
Thanks for the continued support that you give us, and thank you for being here today. Can you give Rob a massive round of applause? Thank you.
So yeah, thanks ever so much again, Rob, for sharing all that great stuff with us, and to Jeff and for doing most of the interviewing, and for Duncan as well, stepping in Jackie's unfortunate absence. So I think we should probably move on to the last session now. So if I could ask Jay and Jabril to come back up, and feel free to sit on the sofa, take a comfy seat on the sofa, and then we shall take some questions from everybody. There's a couple that have come in, so I'll give you the mic, Rob. Right. I'll need a mic. You won't be able to. You won't be able to read my writing, so I shall read them out. But Jay and Jabril, do you want to head up, so that you can sit here? And so if you three want to take a seat, and we can share the mic around. And I'll run around the room with this mic, and you boys can play with that mic. So the first question that we've had is, so there's if a patient was to be coming to your centre to be treated with focused ultrasound, and they also had scheduled to have laser eye treatment for cloudiness post cataract treatment 2 days prior to their focused ultrasound procedure. Would that be something that would concern you as a group of clinicians in terms of offering focused ultrasound 2 days after that? Or what would be your advice to such a patient? It's not personal to anybody in the room, it's a generic, general question.
Yeah, absolutely. Again, Jibril, correct me if I'm wrong on this. I don't think there should be any issues with having the focused ultrasound treatment 2 days after having laser eye surgery.
Oh, that was a nice, easy answer. Great. The next one could be particularly difficult to generalize, but I shall do my best. If there was a late octogenarian, so approaching 90, concerned about how bad their essential tremor might become, and I'm guessing this is a little bit of a how long is a piece of string question, But it's more about how bad can it get, essential tremor? How progressive, how bad can it be?
It can get extremely severe. So, so we use a tremor rating scale, and where I have seen people get the maximum score on the tremor. So it can get extremely severe. Functionally, it can be practically very disabling. They can't do any of the things that we take for granted, as Rob said earlier, like, tying a shoelace, buttoning up the shirt. Everything can be quite difficult. So it can get quite severe as it progresses. Yeah. Fortunately, not in everyone, but there are cases where it can get very severe. Yeah.
So I'm guessing your advice in such a situation would be to get referred to a movement disorder neurologist.
Yes, absolutely. Yeah.
And get some proper clinical advice.
Yeah.
Yeah. Okay, that's good. And then the other thing, just then I'll shut up. You'll be pleased to hear. Is we understand that the focused ultrasound is not available in children, but it's an over 18s therapy. Is that the same for deep brain stimulation? And do you see a time in the future where children, because obviously it's what they call a bimodal presentation, isn't it, in terms of essential tremor, so that there are a significant number of children that do suffer from it. Yeah. Are there any options for children? Or what do you do in those cases?
Yeah, as somebody who has actually done deep brain stimulation in children, I will ask Jibril to answer that one.
So I started the DBS service in Oldham, in the pediatric service. DBS is available for pediatric population. The type of disease and the condition treated in pediatric are very different from adult. So tremors are possibly not particularly frequent. Dystonia and some form of genetic Parkinson are treated, but mainly in pediatric population is dystonia, primary dystonia or secondary dystonia.
Thank you very much. So questions from the room? Raise your hand. There we go. Right. You're in first.
Rob raised a point which reminded me of an issue that I've often thought about. Rob said that he gets some relief by stretching. I wondered for some time whether muscle tone is an issue and whether improved muscle tone helps.
Yeah, okay. So if there is an issue with muscle tone, to be honest, it's much more likely to be a dystonic tremor rather than an essential tremor, because that's how we clinically distinguish the two conditions. So if there is more muscle tone, it's more likely to be a dystonia.
Yep, on my way.
I would like to know, how does one go about getting from going to a GP to get a referral to the clinic? What are the steps involved?
So in the ideal world, what we would expect is the GP to refer to a movement disorder neurologist locally, and then the movement disorder neurologist doing an assessment and then referring patients on. But in the post-pandemic world, the waiting lists are huge, and we do get a lot of direct referrals from GPs as well nowadays, just to bypass. But that does have the disadvantage. So sometimes we see patients who have traveled a long way, and when they actually arrive in the clinic, you realize that they are not actually eligible for the treatment, sometimes because they have never tried any medications ever. So currently it is licensed only for medication refractory tremors. So it is best that a movement disorder neurologist assesses the person first before doing the referral. But as I said, if somebody has been diagnosed before and has had tried treatments, there is no reason why you cannot be referred by the GP.
Yeah.
And a follow-up question to that is, what is the waiting list for the ultrasound treatment?
Jibril, do you want to answer?
So currently, the number of patients possibly is in the range of 35 to 40. So we are doing 2 cases a day. From January, we should be able to go up to possibly 3 cases for a total of 6 patients per week. from January onwards. So if you are referred to our, sorry, a month, yeah. If you are referred to us, more likely within 2 to 3 months you will have the treatment. 4 months, really. Yeah.
So if I'll just add a little bit of colour to that. That applies to the Walton Centre in Liverpool. If you live south, then the other NHS provider is St Mary's. Unfortunately, they've been going a lot longer, and so their waiting list is equally a lot longer. And depending on who you talk to, is anything around can be up to 4 years if you're based in the south, accessing the NHS service at St Mary's. So I think it's only a matter of time before the Walton Centre ends up with a large waiting list too, because we know that 2 providers just clearly isn't sufficient for the number of patients that could potentially benefit. And I think the same would apply for deep brain stimulation as well. I think we should be very mindful that it's horses for courses, and it's important to assess multiple treatment options as opposed to just focusing on one without wishing to pun. Did you had a question?
What's happening in the rest of the country?
I kind of answered that.
Neurosurgeons, have we enough ultrasound equipment?
So I'll answer that for you. The strategy of NHS England has been to actually provide 2 machines for essential tremor, one in the south, one in the north. The one in the south has got already a waiting list of possibly 3 to 4 years, and the one in the north should take on part of the cases of the one in the south. In other words, everyone who lives Birmingham or above should be referred to us, and they should actually, and St Mary should treat the south of England. Then, after 5 years, their plan is to review the provision, and accordingly, with the number of cases, commission more machine in the country. So if you take a European country, so I'm coming from Italy originally, and in Italy there are a total of 7 machines. So there is a machine in Milan, one in L'Aquila, and other 2 or 3 in the south. So for a 70 million inhabitant, you will have at least 3 to 4 machines in the future. But for the moment, everything is capped to 2 machines, and the revision is at 5 years.
Yep, I'm coming.
I think James will probably know, it's a sort of supplement to your answer there. In Scotland, there is a research machine in Dundee where they will allow, the Scottish Government, bless them, will allow research to take place at the University of Dundee, which is attached to the same building as Nine Wells Hospital. For some reason, they won't allow NHS treatment at the research facility. They will allow the NHS Scotland to pay, with the suggestion that Scottish patients travel to England for the treatment. Now, we are, with James's help and the NTF, having a drop-in thing for MSPs in January. It was supposed to have happened last month, but unfortunately Parliament went into mourning with the death of Her Majesty. I can sort of see with you shaking of your head, you either don't know anything about this or you don't think it's feasible for Scottish patients to come either to Liverpool or London for that to happen.
Can I answer this? Yeah. Sorry, I was shaking my head because I think you're not entirely correct. So the individual which are running the MR-guided focus ultrasound in Dundee have placed the machine and the scanner within a research facility, but it's my understanding is that they are treating NHS patient or Scottish NHS patient within the lot of Scotland. So they are receiving referral from Glasgow and Edinburgh, and the surgeon is coming from Edinburgh, and the neurologist is based in Dundee. So I think it's an up and running machine, and I went to see a case there, and my understanding is that they are actually treating NHS patients.
I think it's semantics perhaps between budgets, whether it's a research educational budget or an NHS health budget that it's coming from. But there's still, the Scottish Health Secretary said, yes, Scottish NHS patients can have focused ultrasound, but they'll travel to England. Those that can get through the NTF and in Scotland and other sources, you can say, get your GP to talk to your neurosurgeon, to get in touch with a neurosurgeon in Dundee, get there. But through normal NHS processes don't. And yes, there is the neurosurgery at Queen Elizabeth University Hospital, the Southern General in Glasgow. I know that there is a good connection between they see it, they do the DBS, and they see focused ultrasound in Dundee as something that will take the strain off their DBS. But the official policy of our health secretary, and I can't say his proper name, but I'm useless, is NHS patients in Scotland are going to England for treatment.
I think we're getting into politics. Scotland is a separate country, and the health service, although there's quite a lot of connections across the border, is a separate entity. And I don't think it's really opportunistic of us to try and make comments of if and buts concerning the Scottish Parliament and the Scottish NHS. And as a Scotsman, and I live in Scotland, I'm very sympathetic to what has been said, but I don't think it's useful today to debate with our experts of what's happening north of the border, because it's beyond our control.
I think you had this gentleman here, you had a question.
We know that this is a progressive condition, but I was just wanted to ask, with regard to the ultrasound treatment, is it likely to be any more effective earlier on in the condition than it would be later on? So would early intervention be any more effective at all?
That's an excellent question. I'll pass to Prof. Finley to answer that.
Well, it's very kind of you to ask me to answer that. I don't think anyone knows the answer, but the answer probably is it makes no difference. And the time for having treatment is when treatment is needed. And that be dictated by the functionality and the needs of that specific patient. I don't think there's any evidence that early treatment is going to alter the biological processes which are going on behind the development of tremor. And while I'm on the subject, which I agree with my colleague about the very severe essential tremor, I want to emphasize that very severe essential tremor, totally disabling tremor, which can be as bad as anything in neurology, is extremely rare. That although it's going to get worse with age, the vast majority of people never get into that stage. So I think you'd agree with that. And I think it's important that you don't go away thinking, gosh, I got that to look forward to, because the vast majority haven't. I'm not saying it's good, but it's not as bad as that.
Any other questions from the floor? Yep, got one here from Rob.
I'm just wondering whether or not, is there anywhere in the world where the the numbers of people that have tremors is actually quite a lot less than other places. Is there anything in that? Or is it quite universal across all populations?
There have been limited studies of population studies. There have been a number, and the figures vary enormously. From 1%, I think most studies in the UK have said 1 to 2%. In Sweden, there have been studies, several studies, which have said up to 5.5% of the population. But again, everybody defines when is essential tremor. How do you actually define it in an individual? Is that essential tremor? Is that just a bit of enhanced physiological tremor? You know, it depends where you take your cut off. It's interesting that some of the best studies have been done in Russia. That was before any wars, a long time ago, at the beginning of the last century. And the figures there were between, people actually went out into the villages and actually looked at everybody, which is the best way of doing it. And the figures there were between 1 and 2% maximum.
I think the other thing, just to add to that, is that it's difficult to compare demographics because of population distribution. So saying a percentage of the entire population often can give you a slightly skewed figure, if you will, in the sense that if you live in a country with a much larger, older population, then the percentage of your population will be higher in terms of essential tremor, because we know it becomes more common with each decade that you live. So, for example, Italy has a much higher prevalence of essential tremor than a country that has a much younger population, for example. Any others that would like to?
Just to answer that question another way, I don't think there's been any population in the world where it's absent. Every population has it, and they've had studies up in the jungles of Papua and New Guinea, and going into the villages looking at looking for essential tremor. So every population has it.
Okay, I've got another one at the rack. You would have to sit the furthest away, wouldn't you? Nearly there.
Would focused ultrasound be effective for internal tremors and leg tremors?
So just to repeat the question for the room, would focused ultrasound be effective for internal tremors, I think was the question, and leg tremors? So internal tremors and leg tremors.
No, it won't be effective for internal tremors. Leg tremors, as far as we know, the answer is no.
Thank you. Sorry. Another question over here?
Hi, sorry if this has been asked, I'm late back from lunch. Can COVID increase the severity of an essential tremor?
No, that hasn't been asked. That's a great question. So can COVID make tremors worse?
COVID, so there has been this COVID neuro study, which looked at neurological manifestations of COVID, and it mentions that you can get a new onset of a movement disorder after COVID, post-COVID. Rare, but it can happen. But there is no proof that essential tremor gets worse post-COVID.
Thank you. I'm going to ask another one, if I can. So anecdotally, we've seen from some of the patients that have been treated with focused ultrasound that they get great tremor control in the hand that's been treated, but they seem to notice it more on the other side. What's your opinions on that, whether it's psychological, or is there anything to suggest that having one side treated and tremor controlled, that the other side potentially gets worse, or is it psychological?
I think it's psychological. If I look at the video, pre-op, post-op, and we actually tend to video the contralateral side as well, possibly on a visual point of view, the contralateral side it looks worse because one side is completely controlled, but there isn't really any worsening on the contralateral side that I could see.
Thank you. That was my supposition as well, but I wanted to know from somebody who knew what they were talking about as opposed to me. Here we go, another question here.
Having had the focused ultrasound, Mr. Farrer is the surgeon, Dr. Panica was my consultant. You do get a sense of imbalance because I had my right hand done, and that is absolutely rock steady. As you can see, my left hand is not. So it is psychological to some extent, but it is there. And I notice it more if I'm carrying things with two hands than if I'm carrying things with one hand. I do tend to get a bit more of a shake. It is getting better, and I am reliably informed by the two gentlemen in question at the front that it will improve even more.
Thank you very much. May I ask how long ago you had the treatment? So that was the 9th of June. Your hair grows really fast. I want what you've got.
Just a quick question from me. I'm Kitty. I'm one of the trustees for the National Tremor Foundation, but we've talked a lot today about the physical treatment for essential tremor. How do we support people psychologically with essential tremor? I'm thinking more younger people who aren't available to have some of these treatments. How do you support those now? Does the wider health system look after our people who can't have that kind of treatment?
Absolutely, that's a very good question. So we encounter this problem even among patients who come across, and you can have medical treatments or surgical treatments. We usually refer them on to our neuropsychologists who are based in Walton Center, who actually do an assessment and suggest treatments, which are often delivered in the community. So the psychological impact of tremors is actually the sort of hidden disability, really. Like it has a huge impact on people, and that's often, as health professionals, we often are not, conscious of that. That's something that we don't see, to be honest, and we are guilty of not addressing it properly, actually. Yeah.
Yep. Got another one.
Hi, yeah, I was just interested because I've had essential tremor pretty much since I was born, but I know that it can come on at any time. So I was just curious, is there any reasoning why, for instance, someone might be born with essential tremor versus why someone might develop it at like age 60?
I think you're asking, is there any physiological difference between early onset and essential tremor in the elderly? And the answer is no, there isn't. The mechanisms are the same. With the elderly, you always get elderly patients, and I put myself in that group, we're not clean. We're always a bit ragged, and there's always other things going on in our nervous system just because we're old. And so there are differences, but fundamentally, the tremors are coming from the same source, and they are the same, though frequency slows down as you get older, but it's basically the same. Does that answer your question?
I'm stood in entirely the wrong place to assess the room. Question?
I want to know about the correlation between essential tremor and pain. Does it cause pain, muscular pain, or is that a completely separate condition?
No, there is no correlation between essential tremor and pain. It is not a condition which causes pain. But one can imagine if you have a head tremor, and if you're underlying cervical spondylitis, which is arthritis of the neck, and the constant movements of the head obviously will exacerbate the pain from spondylitis, but by definition, it's not a condition which causes pain.
I feel like an auctioneer. Has anybody got any more questions? Going once. Well, in which case, I will thank you all for coming. I would especially like to thank Prof for leading our day today and for introducing our esteemed guests and speakers, and for leading the expert panel. Thank you, sir. I'd like to thank Dr. Jay Panika, Mr. Jibal Farrar, for giving 2 fantastic talks, and also for staying for the expert panel question and answer. And of course, thank you to Rob for giving up your day and for being available to answer questions and chat with people and to share your experiences, which I think are invaluable for us to really learn from, benefit from. Thank you. And I'd also like to thank the guys that were manning the tables out in the refreshment area. So the Disability Partnership, Boston Scientific. I'm going to forget someone, I know I am. Karen from doing the wellness area. My colleague Anna with Insightec. And hopefully you managed to glean some information that's useful, being able to have that opportunity to network and just learn a little bit more about essential tremor and what is available or can be available. And I wish you all a very safe journey home, avoiding railways. And I'm sure I'll see you on various online meetups with Jackie and her support group. So thank you very much.
Thank you.